Hello, my name is Gary Goldenberg. I'm on the advisory board of the Foundation for Research and Education in Dermatology, the sponsor of the Fall Clinical Dermatology Conference. The purpose of this conference is to unlock your potential by providing practical education that you can apply immediately. Therefore, I'm pleased to be hosting this discussion on when to use oral systemic therapies in the treatment of moderate to severe plaque psoriasis. I'm very happy to be joined by my friend and colleague, Dr. Leon Kirchik, who will help to provide some insights on this question. Leon, welcome, and thank you for being here.
Good morning, Gary, and thank you for inviting me to your beautiful office here in Manhattan.
Leon, what are your considerations for systemic therapy for patients with psoriasis?
So there are several issues. One is large body surface areas, right? It is very, very difficult to apply several creams several times a day on those areas. That makes the compliance also difficult. Psoriatic arthritis, regardless of the body surface area, psoriatic arthritis is very important because most of the psoriatic arthritis patients have less than 5% body surface area. When you look at the numbers, 64% of psoriatic arthritis patients actually have less than 5% body surface area involvement. And no creams are gonna help psoriatic arthritis, right? We do need systemic treatment. There are patients with needle phobia. We use a lot of biologics, but on the other hand, there are patients who don't wanna use needles, who don't wanna do injections, then we do need oral systemic treatments. And then monitoring is important. With most of the biologics, we still have to worry about tuberculosis, serious infections, even immune suppression, and cancers. So oral systemic medication, such as apremilast, becomes very useful when we don't worry about monitoring.
So that's an interesting point you brought up with psoriatic arthritis, because I think that most of our colleagues would think that there's a direct correlation between having a lot of psoriasis on the patient's skin and having joint involvement, when in fact you could have, as I say, 2 plaques on your knees and 2 plaques on your elbows and have the worst, the most debilitating psoriatic arthritis, or you could have 90% body surface area involvement of psoriasis and no arthritis. So there's not a direct correlation, which is why every patient needs to be screened for psoriatic arthritis. And as you mentioned, we know from the data that over 60% of patients had less than 3% body surface area involvement.
So absolutely, that's a great point that you brought up, that the perception that most patients with psoriatic arthritis have large body surface area involvement or severe disease, it's just a myth. Now we know that almost 64% of all psoriatic arthritis patients have less than 3% body surface area. Most of those areas that are involved are gluteal area, scalp, as well as the nails. And we know that actually by looking at the nails, you actually recognize those patients may have psoriatic arthritis.
That's a very good clinical tip, because if you're not examining the patient's nails, if they have mild disease from a dermatologic point of view, and you're not screening them for psoriatic arthritis, you're gonna miss a lot of those patients. And we know that it's important for us to screen them because we're sort of the first line of defense, because most patients develop skin disease before they develop joint disease. And sure, it's important to work with a rheumatologist, but unless the patients are aware, we're not going to get there. So it's important for us to screen those patients.
So 75% of all patients first present with skin problems. About 15% will have both, and 10% will just have joint problems. So again, we're on the front lines. As dermatologists, we're seeing those patients, and it's really upon us to see those, to diagnose them early, the psoriatic arthritis, and we'll talk a little bit later about the actual consequences of late diagnosing those patients, but there are quite a few problems with that. So our treatment options for psoriasis, definitely we have the topicals, but we discussed that psoriasis is a systemic disease, so we need to consider systemic treatment. The first generation systemic treatments that I always call the methotrexate, cyclosporin, they have end organ toxicity. So we have been always concerned about those liver toxicity, kidney toxicity, and we don't want to use those drugs for a couple of patches of psoriasis. And that's where that shyness comes from in dermatology community from using systemic treatment. We have light treatments. Light treatments work very well, but also it's a compliance issue with the patients. It's very difficult to come to your office 3 times a week. And again, light treatment is not gonna do anything to your joints, right? So that brings us to biologics and the small molecules. And apremilast among the small molecules is the only one that's approved both for psoriasis and psoriatic arthritis.
So I just want to go back to considerations for systemic therapy because I think it's important. And the other areas where I think it's very important to at least have the conversation about systemics are scalp disease, hand-foot psoriasis, and genital psoriasis, because the diseases of what we call special sites or difficult to treat areas are difficult for us to treat and they're difficult for patients to live with.
Right. So that's another good point that you brought up. Those areas, they only have, if you add them up, 1 or 2% body surface area, right? Palmar plantar psoriasis patients are probably the most miserable patients because they cannot walk, they cannot do their work. It is a very difficult situation for those patients to be able to use their hands, and some of them, they cannot even step on their feet. It's so painful, and I think it can be one of the most common reasons for disability in dermatology. But the other problem is that with third-party payers, because they have less than 10% body surface area, they may not qualify for systemic treatment. Hence, it's upon us really to fight for our patients and make sure that the third-party payers understand that those patients also need systemic treatment regardless the body surface area.
I think it's very important to consider those special sites and the fact that psoriasis is a systemic disease opposed to just a skin disease like we talked about. So let's get back to the most common systemic manifestation of psoriatic disease, which is joint disease. And we know that it's very common. I remember when I started in dermatology, we used to say that it's under 10%, maybe 8-10% of patients with psoriasis have psoriatic arthritis. And now in some studies, it's over 40% of patients with psoriasis having psoriatic arthritis, changes on their MRIs and symptoms. So I think it's very important for us to screen and treat those patients if we are going to choose a systemic, like apremilast or biologics, for patients with psoriasis, because you want to make sure that they also have approval and efficacy for psoriatic arthritis. And I know you have experience in clinical trials, specifically with apremilast, doing that research.
Absolutely. I was lucky enough to be part of both apremilast psoriasis as well as the psoriatic arthritis studies, and we did get good ACR20 response at week 16 that got the approval for the drug. And also we have numbers for ACR 50 and 70, long-term safety and efficacy studies.
Just for our viewers, it's important that they realize that ACR is a standardized measure that rheumatologists use in their study, and we sort of don't really use in the clinical practice. It's an approved measure of symptom relief of patients with psoriatic arthritis. So let's talk about monitoring. You already touched on this. And I think a lot of patients will sort of think that if you're using a more serious medication, you're going to need sort of constant and ongoing monitoring. So I think that lack of monitoring or no sort of FDA required need for monitoring makes the medication appear a little bit safer. What do you think about that concept?
Absolutely. And even though biologics have been around for a long time and they have a long-term safety efficacy data, they still require monitoring. I always check a CBC, comprehensive metabolic panel, of course tuberculosis, as well as hepatitis B and hepatitis C profile. And because we have to be concerned and careful what kind of biologic we are using in hepatitis patients. So that makes apremilast quite a valuable tool in our armamentarium where we don't have to worry about monitoring. And that gives that safety thought to the patient as well as to us.
Yeah, I totally agree. I personally, in my practice, I like checking labs, and I check a lot of labs on patients with biologics. And like you, I agree that biologics are very safe for the appropriate patient, but I think that it's great to have multiple options because not every patient is going to do well with each drug. And in my practice, especially for patients who are needle phobic or who are sort of shy about going to a biologic, I always say it's easier to go from a topical to an oral systemic like apremilast and then jump to a biologic if they need it, or if they don't need it, just kind of stay there. So I think it's very important that we have those options. Okay, let's get back to psoriatic arthritis. The one thing that I think is instrumental and is very important for us to think about is how terrible it is to have a delay of diagnosis in psoriatic arthritis, because that's permanent, irreversible joint damage, and we're on the front line, so we're responsible for screening those patients with a review of system and maybe sort of a rudimentary rheumatologic exam. What do you think about that?
Absolutely. Now we actually have data, and the data comes mostly from Europe, that even delaying the diagnosis of psoriatic arthritis for 6 months may cause a lot of irreversible damage. And really treating the joints, unlike the skin, diagnosing it early and treating it early will prevent further joint disability, which is irreversible.
Sure, the skin has a lot of regenerative potential. You could have somebody with terrible psoriasis that you can clear, and then their skin may look a little bit hyperpigmented or slightly erythematous, but there's no permanent damage. Whereas with joints, once that damage is done, it's done, which is why I think it's so important for us to really work with our rheumatology colleagues to treat these patients together, because it has to be a holistic approach where we're treating the skin, the joints, the other comorbid organ systems. So working with rheumatologists and other internists is so important for us.
Absolutely. So we have to raise awareness, not only with our patients, but also with our colleagues in primary care, where they understand that psoriasis is a systemic disease with comorbidities, with cardiovascular problems, with obesity, high blood pressure. So again, I think it's important also for our patients to understand that joints and skin go hand to hand, because when the patients come to me and they say, "Doc, why are you asking me about my joints?" They are really, they don't know, they have no idea about psoriatic arthritis. So it falls upon us in dermatology to raise that awareness, both with our patients and as well as with our colleagues.
And I think this is why systemic therapy is so important for us to consider, because we're not only treating skin disease, we're treating the patient in a holistic, what I call holistic dermatology way, where we're not only treating their skin and joints, we also have to worry about mental health. Depression, we know, is common in patients with psoriasis, eye disease, cardiovascular disease, gut disease, kidney disease, metabolic syndrome. The list just goes on, and I feel like every few months there is a study that shows that psoriasis is now associated with yet another systemic condition, because we know how important systemic inflammation is. So therefore, treating it systemically is very, very important.
Absolutely, and in order to achieve that, I think we have to work in a team fashion with the rheumatologist, with the internist, with our colleagues, in order to be able to handle those patients appropriately.
So there are several systemic therapy considerations that we have to sort of think about then. You have the clinical consideration, you have the patient sort of preference, and I think that's, I always say that getting the patients on board with what you're doing is going to improve compliance. And then you have to talk about sort of long-term efficacy and long-term monitoring. And then you want to have that team-based approach where you're working with a rheumatologist, with a cardiologist, with a kidney doctor, whatever problem the patient has, to make sure that we're treating them in a holistic way.
I think you summarized it wonderfully.
Thank you.